Our case today is a challenging scenario. Maybe it's not repeated too much with this high-risk events. It's a complicated STEMI case in an old age patient. Our patient is an 8-year-old female patient, housewife. She's diabetic for 15 years on insulin. She didn't have previous cardiac history, and she was presented to our ER by severe dyspnea and orthopnea for 3 hours. The patient was oriented to time, place, and person. Her heart rate was 95 beats per minute, and blood pressure was 150/90. Respiratory rate was 19 per minute, and chest examination showed bilateral basal rails. Cardiac examination showed apical S4. Her EKG showed extensive anterior STEMI. So we proceeded directly to the cath lab for sure. Here is the left system. Shows total occlusion of the LAD with extensive calcium. Some dilatations and aneurysms in the circumflex with diffusely diseased vessel. And the RCA fills retrogradely. These are other projections. The RCA showed CTO and fills retrogradely from the left system. Sure, we'll begin with the culprit lesion, which was the LAD. But should we only address the LAD, or then we should proceed to the RCA? According to the guidelines, the patient was not hemodynamically unstable and was not in cardiogenic shock, so we didn't plan to operate the RCA at that stage. We passed the wire in the LAD. And then we wanted to make sure that we are in the true lumen because the wire was a little bit difficult to pass. We tried the closed balloon, as you see it, to go distally to the LAD to make sure that we are in the true lumen. And then the patient developed VT on table. The flow in the LAD was not so promising, and the distal diffuse diseased vessel rendered it difficult to know from where to where should we put the stent, or which part should we stent and leave the other. And it was not possible to do a full metal jacket for sure. The actual culprit lesion was in the proximal part, as you see here in the caudal projection. The total occlusion was there. Then we pre-dilated multiple sites because of the extensive calcification, so the stent would not pass easily. The flow is not very good.
What is that?
Yeah, the patient was irritable after the PT. She received DC shocks, okay, and she was irritated so much, but she was not in cardiogenic shock. The flow stopped again in the LAD. Unfortunately, we didn't have at that time thrombus aspiration catheters that should be used. We pre-dilated again. The flow was much better at this point. So we found that there is a landing zone in the mid-LAD here to stop the stent at. But we needed 2 stents because the lesion was so long to be covered with 1 stent. So we put the distal one at first because of the calcium also. So the first one would pass easily. There was some haziness at the edge of the stent. It was relieved afterwards with the coronary dilators. This is the second stent. We put it overlapping with the distal one. And this is the final result with the 2 stents. The result was STEMI 2 flow in this image. We give intracoronary isopten, verapamil, and nitroglycerin. and the flow improved in the last one. The patient did well in the following days, and we decided to follow up her with medical treatment and not to address the RCA-CTO if she became symptomatic afterwards. And also the LCX PCI will be more risky than more than she will benefit from it because of the aneurysms in it. And the patient did well for more than 6 months till this point. I think the take-home message in this case, the proper decision in the acute event or the acute STEMI patient gives better results, which vessel to target and which vessel to leave at this point. I think this is very important. Also, the direct stenting may be the best option in most STEMI cases, but in some cases like this with heavy calcification, we should pre-dilate and prepare the vessel prior to stenting. Thank you.
Okay. The case is now open for discussion.
Just 2 points. First of all,
You want, Lena, use your, yeah.
just 2 questions. So one is when you're struggling with some slow reflow issues and wondering about your stent edges and what have you, did you consider intracoronary imaging and quick IVUS or anything to look at that further?
Yeah, it would be beneficial, but we didn't have it on site this time, unfortunately.
Okay.
Yeah.
And then the other thing would be in this individual, they have the CTO of the RCA, significant disease in the circ, and then you're struggling with your infarct vessel
Yes.
rails, I think, on exam. Any value for a quick EDP or right heart cath and or consideration of hemodynamic support?
We didn't have LV support device at this time as Impella or intra-aortic balloon, but it will be beneficial also.
Well, we don't know if the patient is if the patient has normal blood pressure.
Yeah,
I mean,
the blood pressure was
not
normal.
Hypotensive, she's not in shock.
No,
maybe
she had some
we
lung
don't know whether we
congestion
should do it.
Yeah, I think knowing the
because she's a high-risk patient. Yeah, but
It's
she
a
was not
high-risk
shocked.
patient. You have to be on the fence with that, but that doesn't need. Did you
Yes.
do it radially or?
No, femoral,
Or
right femoral. Yeah.
Okay. Is there a reason? Are you mostly femoral lab in your?
Femoral more than radial. Yeah.
More-
We
femoral
do
more than
radial, but
radial.
more femoral more. Yeah.
Okay.
Yes, I totally agree. I totally agree about the and definitely a right heart cath would be important. Also, lactate. They've seen in cases like this, like lactate more than like 9, 12, means that already the metabolic cascade has taken off. And if it's less than that, then it's definitely worth putting a device in. But I think it's a great save. Looking at those arteries, I was living in that crappy circ, and you opened up the LED, she went home, and that's wonderful.
Yes.
Yeah, good judgment overall to take care of this patient. Those lesions were very complicated, very diffuse, and then embarking into a CTO at that time was in an old patient. I mean, you would have probably shut down the kidney. So, and
Yes,
then,
we did it in very short time, about 15 minutes, all the procedure, and very small amount of contrast. So we didn't want to take another risk with the patient at this time.
Perfect. Well, I think that I don't know if you have any comments, Harry. Okay, any comments? No, we're gonna move so we can catch up. Okay.
Okay. Thank
you.
Thank you.